everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Mayank Pant. He's EVP Product Management at IKS Health. Welcome.
Thank you, John. Pleasure to be here. Thank you for taking our time today.
Yeah, excited to dive into some of the new innovations that you're doing at IKS Health and ways that you're engaging patients in unique ways, which, and perspectives on that. But before we go there, tell us a little bit about yourself and IKS Health.
So, name's Mayank. I lead the product teams at IKS. We've been thinking about how do we disrupt the whole patient journey from schedule to cash. Today, this is one such innovation. IKS, I think the way we like to think of ourselves as care enablement company that uses cutting edge technology, AI or whatever else there is out there with human in the loop to solve for some of the chores that sort of plague the healthcare community today and have them go back to what they do best, which is focus on the patient care, think about growth, think about their own well-being.
Interesting. When you look at engaging patients, what's the difference between outreach to patients versus engagement to patients when it comes to healthcare communications?
It's, if I can just summarize it, it's outcome, right? Outreach, unfortunately, is sort of sometimes masquerades as engagement. Most of the time in healthcare is very unplanned, has no tonality, has no understanding on the patient preference, and what most importantly doesn't necessarily deliver any outcome. So your ability to text me, your ability to email me, it just simply forcing you to sort of reach out to me. Engagement, on the other hand, is expected to deliver an outcome.
Okay.
So if you can take outreach and convert that into an outcome could be if you can convince the patient in this case to perform a certain activity that without this impetus they might have not done it, that's engagement. So outcome is sort of what separates them both.
So interesting. It's almost like I checked a checkbox, I sent you a reminder.
Yeah, that's exactly what's going on.
Versus actually caring that the patient really gets the message. And
that's why everyone's frustrated in this process. That's why your text gets swiped out and it delivers no real outcome.
Amazing. What are some of the patient access pressures that organizations are feeling? We're here at the AMGA conference. I'm sure you're hearing a lot of from different people about the pressures they're feeling. What ones are you hearing?
I think there are plenty out there, right? There are a couple that I think are very relevant today. One of the big one is just the time it takes to seek care. Even while there is well intent, even while the controls in place to sort of make that happen between both the provider and the patient just takes incredible amount of time to seek care, and a lot of that is happening because of the inefficient utilization of schedule. So that to me is one of the big things that jumps out. Even if you can't do much about the demand and supply gap, and what I mean by that is if you can only see 7 patients a day, can you make sure that you reliably see those 7 without having cancellations and no-shows? And of course that leads to frustration on both sides. The patients are frustrated, providers are frustrated, they're getting burnt out. Prior auth is another huge area. Everyone talks about it. The challenge in the prior auth is it punctuates the care journey for the patient. So I'm in a pain, I gotta get something done, but I just cannot do that because some approval, or in this case a prior auth is needed. Is another big area that I think keeps surfacing, and it should be it's a theme all over AMGA as well.
Yeah, interesting. So if we want to move to real engagement, how should we be measuring engagement versus I think a lot of people just measure activity, I did this activity, I sent this many emails. So how do you measure engagement?
Operating word is outcome. We just talked about that. In the end, if the said outreach delivered the intended outcome. Some of the outcomes that you could look at and say, me as a patient, I'm sure John, you as a patient, you have no interest in trying to fill up forms, click on the links, do whatever you need to do. You're seeking care. Anybody who comes between you and the provider is a villain. Where the technology can genuinely help is, can a AI do those tasks so the patient can go see the provider when they need to. So those are some of the way the measurable results can deliver. It's all about outcome. Certainly outreach has a place in place. You could finding out what channel you can engage the patient on a text, on an email, or on a call is certainly important. But does it deliver the outcome it's intended? That's the key. An outcome could be, like I said, the scheduling is, reducing no-shows, making sure that you offer up a slot to the patient at the confluence of their preference and providers availability and the facilities availability are some of the outcomes that you could look forward to deliver.
Interesting. So if we want to, really influence outcomes, what is really needed to make the engagement and the action from the patient happen so that we get the results and outcomes we want?
We've done a lot of work on this area. We've spent good 2-3 years analyzing a lot of information about when we say patients don't engage, what is it that is making them not engage? And the data has the answer. One of the use case or example that I would give you is patient attributable medical debt is rising. Okay. We have this false sense of insurance coverage in the industry because people have gone from insurances that are covered large part of the care to these metallic plans that now on the exchange that have a high deductible plan that don't necessarily cover anything. And one of the things that we've sort of come up with is this very interesting idea. It's a behaviorally segmented algorithm that tries to understand the motivations behind the patient's behavior. And one of the ways it manifests is if you look at the patient's proclivity to pay or lack thereof, we think it's a function of 3 things. It's a function of something as simple as awareness. Okay. Am I even aware that I owe this money? When I go buy a pair of jeans, I know what it costs, right? So awareness is critical. Do I have the ability? Can I buy this pair of jeans or not, right? And ability probably also has an intrinsic factor on how easy are we making it for them. So ability has those 2 connotations. And then the third is willingness. Is if I have high ability, high awareness, am I willing to do this? Now that willingness is a very deep-rooted problem. It's deeply behavioral. It's also there's almost a lack of deterrence in the industry. Nothing really happens if you don't pay. No one's holding you accountable. Part of it is a data problem, not knowing who has an awareness, ability, and who has a willingness problem. So then sort of think about it, summarizing this then, right, John? The engagement is personalized. Engagement is goal-seeking, outcome-dependent, and engagement has to behaviorally understand the motivations, why the patient is not engaging, and then you have to attack at that, and then perhaps outreach can get you there.
Sure. I feel like I'm in a bit of a therapy session as a patient because I think I've been in all 3 states.
For sure, yeah. For sure.
I haven't been aware of what I needed to pay. I haven't been able to pay when I was younger. And am I willing? That's always a tough one. That's fascinating. Well, I mean, IKS Health is really leveraging what you're calling behavioral AI and a solution that has behavioral AI embedded, which aligns with what you just talked about. Talk to us about what that means from a solution perspective, and what does that look like for a healthcare organization that wants to leverage IKS Health?
Yeah, I think we just talked about AAW, which is the patient propensity part of the model. It could have, in the past, this was a brute force mathematical model where you just code the patients based on past behavior without understanding that behavior is because of what reason. So that's one example. Another good example is in the no-show and the cancellation world, right, where almost 20% of patients just don't show up for the care, and that could, as you can imagine, leads to all kind of issues down the stream. We've created another algorithm that starts off by predicting the patient's propensity to keep an appointment, cancel an appointment, and also, going further upstream, and saying what is the right recommended slot at the confluence of provider preference and a patient preference. So if you lead with the preferred slot and follow it up with a propensity to keep or deliver an outcome, it almost presents itself I'm not going to say 100% accurate, but a very reliable mechanics that you could then use to drive some behavior. Now, when you put a trigger like this into a self-orchestrating system, which is what MyCare Hub does, it's a self-orchestrating system. Self-orchestrating here means that it has an ability to take an input and deliver an outcome, right? So these are some of the ways how we've tried to not create another framework, but create an approach that can scale, or a vehicle that can take us to the next stage.
Interesting. It almost reminds me of RevCycle, where they're like, can we go upstream of the claim denial and basically solve the data problem so we don't get the claim denial? You did the same with appointments. Like, can we go upstream, make sure they schedule the right appointment? I love that. That's an interesting comparison and the same approach that makes a lot of sense.
Yeah.
I think what's also interesting about what you just described is it feels like you're putting the patient at the center, whereas most of the others were like, hey, let's send a reminder so that we get more revenue. Like, talk about how putting the patient first allows you to still generate the outcomes that matter for a healthcare organization.
I think put a word out there through your platform, if I can do that. Unfortunately, patient being so critical in the journey hasn't been given the sort of the status they deserve. Almost every other patient engagement system out there is an afterthought, emanating either out of a system of record or emanating out of a point solution environment without thinking about what the patient's looking for. I gave you an example earlier. As a patient, I want to have nothing to do with your links, whether they're received on an email or a chat. I want to see the doctor. So someone said, some time back that if AI could do my dishes and do my laundry, I can then write music. This is no different. A patient saying, I want a concierge to take care of my chores so I can see my provider. And that's what the patient mindset is all about. Don't make the patient do stuff that they don't want to do. Why would I need to ask John the same information I asked him last time? It's not like your information has changed. There's all of this information already available. Make it easy for the patient to take a decision. And one of the big theme or a behavioral framework we use in MyCare Hub is this idea of, give something to get something.
Yeah.
So there's a very interesting concept we've come up with called Swift Pass. Swift Pass, think of it like a TSA pre.
Yeah.
Once you've done one successful onboarding, you're now given a Swift Pass that has a validity of 3 months. Well, imagining that 3 months information could change. Once you as a patient has a Swift Pass, John, then your journey from there on is fully autonomous.
Wow.
An AI agent can take care of it. So I'm visualizing at some point of time, and we've deployed this in one of our clients recently. There is a lane in a clinic called Swift Pass, where patients who have Swift Pass have a peace of mind to be able to see the provider, vis-a-vis the others who have incentive to be on a Swift Pass. No different than an airport situation. So those are some patient-first principles that are. And this technology is wired with the patient first as a mindset.
Yeah.
It wasn't sort of restructured from an older application to be built. It's built recently, so it's built with that mindset. And we apply the lens and say, is this making the joy? Is this making things happy for patient? Is it going to deliver the joy they're looking for in this painful journey of seeking care? If not, we don't do it.
Interesting. Well, you gave a few examples, the appointment, the pass to be able to get in quicker. Are there any other examples of what this would look like in a practice?
At the end of the day, all this fancy talk has to deliver some results.
Yeah.
We're no different here. With one of our customer, it's a large orthopedic practice enterprise. When we analyze the last 1 year data on the patient attributable balances, and because that's one of the tangible ones out there, that's a hard factor. We're already noticing 8 to 10% pickup in better capture of the patient attributable dollars, but most importantly, this capture is happening before the visit.
Wow.
And to me, this is a needle mover because we're not just collecting dollars that they were being sent statements for. Because we're generating price transparency ahead of time, we're seeing patients willing to pay even before a claim has been adjudicated. Now that's again, these are green shoots. I don't want to get ahead of us here right now, but to me, this is a signal that I think we should worth chasing. Of course, their CSAT has gone up. We're noticing all repeat patients, and in their case, about 55% patients have Swift passes, which is pretty phenomenal because these 55% patients don't have to do any more of the paperwork and nuisance before they seek care. So I need a care, I go see my provider, go back home.
Yeah. I've always said that if there was one place I could just fill out the forms and not have to fill out that again, we would all do it, right?
100%.
Sounds like that's what you're creating.
It's awesome. Common sense stuff that, I don't know why it hasn't been applied in healthcare before, but I think that's just what's good for the patient, it's good for the community.
That's awesome. Well, Mayank, I appreciate you taking time out of your busy schedule here at AMGA to talk with us and share about this great solution and the ways you're helping practices and also patients, more importantly. So thanks so much. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting applications. Thanks so much.
Thank you. It's awesome.